Hello everyone, I am Dr. Vivek Agarwala, Consultant Medical Oncologist from Narayana Super Speciality Hospital, Howrah and R.N. Tagore Hospital, Kolkata. Today I will talk to you about systemic therapy in muscle-invasive bladder cancer when used as an adjuvant modality. So before we go into that, we must know that the standard of care for all muscle-invasive bladder cancer includes neoadjuvant systemic therapy with either a dose-dense MVAC protocol or a gemcitabine cisplatin protocol followed by radical cystectomy. However, we must know that there are around 40% patients who would not be eligible for cisplatin based neoadjuvant systemic therapy because their creatinine may be high and their kidney may not be functioning well. So in these cases, the standard of care goes for upfront radical cystectomy. So before we go into adjuvant systemic therapy, we must know that in muscle invasive bladder cancer, there has not been any large clinical trial or multiple trials which have consistently showed an overall survival benefit for adjuvant systemic therapy or chemotherapy. The main reason behind this is that there were multiple trials that were conducted, but there were poor accrual for all these trials and the trials were very heterogeneous, because of which no trial could ever prove overall survival advantage for a platinum based chemotherapy in adjuvant setting for muscle invasive bladder cancer. If you look at the EORTC study, which was one of the largest studies that looked at adjuvant chemotherapy in bladder cancer, the trial was stopped early because of poor accrual. But when the results of the trial are seen, then there was a significant 14% DFS advantage in favor of adjuvant systemic therapy, which gives us a very good evidence that adjuvant systemic therapy does act well and it should be considered if a neoadjuvant systemic therapy is not considered. And extrapolating from the advantage of neoadjuvant systemic therapy, we can use a dose-dense MVAC cisplatin based chemotherapy or a gemcitabine cisplatin based chemotherapy in the adjuvant setting. Now, in the last few years, there has been a very keen interest on the role of immunotherapy in adjuvant setting in bladder cancers, and this is again an extrapolation of data from the metastatic setting, where in the patients which are not eligible for platinum based chemotherapy and are PD-L1 positive, the upfront treatment with immunotherapeutic agents like pembrolizumab or atezolizumab have shown good results, as well as in the second line setting where immunotherapeutic measures with pembrolizumab or avelumab have got good evidence, as well as in the maintenance setting where avelumab has shown good evidence. So trials were done to see whether immunotherapy could act well as a maintenance or an adjuvant strategy in muscle invasive bladder cancers. So there were two trials, an IMvigor study and the Checkmate 754 study, and out of these two trials, although the IMvigor trial did not show a significant difference in DFS, but the Checkmate study showed a significant 10-month difference in disease-free survival when an adjuvant nivolumab is given as a maintenance strategy for up to 1 year. So the current dictum for adjuvant immunotherapy in muscle invasive bladder cancer is, if on neoadjuvant systemic therapy patients have had complete pathological response, then we can observe them. But if patients have pathologically residual viable disease, then it is preferable to give them adjuvant immunotherapy with nivolumab for 1 year. Also, the data was stratified for PD-L1 positivity or negativity, and the PD-L1 positive patients benefited much more as compared to the PD-L1 negative patients. So an adjuvant immunotherapy is preferable for PD-L1 positive patients. Mature OS data is still pending, but the data looks promising and it is already approved by FDA. So to conclude, the adjuvant systemic therapy in muscle invasive bladder cancer consists of chemotherapy with platinum agents if a neoadjuvant chemotherapy has not been given, and it consists of nivolumab for 1 year as a maintenance if complete pathological response is not there post neoadjuvant platinum based chemotherapy and if the PDL1 is positive. Thank you.